clear it's your idea rather than it's a bottom-up idea rather than a top-down idea. Okay, and that's where you really need to have the high quality of the business case that we're going to be talking about. Okay, so the caveats I'm going to put in today are that every organization has a different business case procedure. So the first step you need to do is understand what your organization's process for developing and assessing business cases are. Every organization will have different templates and different contents within those templates. What we're going to be talking about is the broader basics and the elements that all business cases should have. And this is based on something called the Better Business Cases model. And it's also it's also called the 5 case model. It is what all public sector business cases should be based on. Okay, and this is done by the Treasury. It was developed 20-some years ago, and it's the same process that's been followed through since then. It is broadly very similar to business plans that you get in the private sector, but we have some specific quirks for public sector investment. Okay. There are courses on writing business cases, but they are really designed for people who work in the civil service, who do multi-million-pound business cases. And the processes that they follow within the Better Business Cases courses don't really follow the same processes that we follow for our NHS process. Okay, so this is a simplified version of this wider kind of concept. So the first step is to understand the process, okay, within your organization. The second thing is, do you actually need a business case, or is it something else that you need? And again, every organization will have a different setup. Is it you actually just need an options appraisal because the money's in there, or it's the money's already been budgeted, it's already been allocated, and you need to decide what you can spend it on? So is it an options appraisal? How are you going to spend that money? Or do you need a pitch for a business case? Is this a project business case, which is what we're going to be talking about today? Or is it a program, which is several business cases that are put together, all interrelated and interdependent? Okay. So what you need to work out, first of all, is what level of business case do you need? And then what goes in a business case? Well, it's everything, isn't it? It's the who, what, how, where, when, why. It's all those concepts that have to go within the business case. And what we're going to try and do is put that into a structure. So the aims of a business case are that it needs to be desirable. It needs to be what the organization wants. Okay, it needs to be something that the organization is aligns to the priorities of the organization. It needs to be viable. So you need to have, what you're asking for needs to be viable. It needs to be within the reaches and stretches of your organization, and then you need to be able to achieve it. Okay, whatever your aims are for the business case needs to be achievable. Okay, so it's setting realistic expectations, and that's the first kind of bits of criteria that they're checked on. I'm going to talk a bit more about the structure now. So what we're going to use is this 5-case model. Okay, there are 5 components. A business case is a team effort. Unless it's a very, very small business case, it's very difficult to write one on your own without help from other people. And that means clinical teams, operations teams, finance teams, potentially HR, procurement. All those people need to be involved and have some say in developing a business case, depending on the actual nature of it. So the areas we're going to focus on mostly are the strategic case and the economic case. I'm going to touch a little bit on the commercial case, but that's where you really do need expert help. Again, we'll touch a little bit on the financial case, but again, it's where the finance team come into their own, and then we'll talk a bit about the management case at the end. Okay, so they're the 5 building blocks of the business case. And we'll try and use some examples to demonstrate how they would work, and some tips at the end of how you can best write your business case. What is it that drives a business case? Now, the biggest reason for failure of business cases that I've seen is that it's very obvious when a business case has been written with a solution in mind. So that means that everything else is, the solution is very detailed, but all the other options, all the other processes are not very detailed and are not really thought through. You've not rationalized or reasoned your business case in a clear way. Historically, business cases were there to drive income, particularly in secondary care and the acute sector. They were there to drive income. So you pitched a business case because you wanted to bring in more income. More recently, that's really not an option because the commissioners don't have the money to bring in income. And there's been an understanding that there are cases where the cost of providing the service that you're trying to produce outweighs the income that you're generating. Okay. So the main drivers of business cases now are to solve a problem. You can have business cases where you want to improve quality. It's where you're okay, but you want to step up, and that's good. But the primary driver for most business cases and the ones to get prioritized the most are where there's a problem. And we go back to this value equation. So in my initial talk back in earlier this year, we talked about value and what its role is. So value is quality over cost. Okay, that's how we're going to define value in this context. And there are three components to quality. There's clinical outcomes, okay, and it's not a specific outcome we're talking about, but whether it's patient-related outcome measures, whether it's mortality, whether it's length of stay, there are a variety of different outcomes you can use, but you have to show an improvement in clinical outcome. Patient experience and patient safety. Now, when you're doing a business case, you have to show an improvement in quality. It has to be in at least one of the domains, but the best business cases show improvement in all three domains. Okay, so improvement in outcome or experience or safety, ideally at least two of those three should be improved. Okay, if there's no improvement in quality, it doesn't matter what your solution is, it's not going to get funded. And then you have your revenue and capital costs. Okay, so your revenue or your recurring, ongoing costs, and your capital costs, your big upfront costs. Now, I apologize if this is teaching how to suck eggs. I'm just going through the basics and putting the building blocks in first, and then we'll develop it as we go through. Okay. So the guy that came up with this equation basically suggested that in order to, you have to show that the improvement in quality justifies the cost expenditure, first of all. Second thing you need to know is that improvement in quality will always reduce the costs, but they may not be to your department. They may not be to your organization. They may not be even to your ICB. There might be societal benefits. There might be to environmental benefits. There may be other benefits that you can put in. Okay, so in terms of cost reduction, but you have to show that improvement in quality. So this is my kind of crib sheet, and we'll kind of keep coming back to this as the talk goes through. Okay, so we're going to focus on the strategic case. And so the bits of the strategic case is it needed? Why do we need to change? What are the risk benefits? And I said you need to show a quality improvement in quality. So if we take the first step, strategic case. So the business, you've got to have a way of aligning whatever your business case is for to the strategic context. Okay, so whatever your plans, your organizational plans are, your aims are, whatever they are, your business case has to fit that. In order to get it prioritized, it has to fit that. Okay. It also can't negatively affect any of your key performance indicators. So whether it's the 2-week wait, whether it's the 18-week wait, or whatever your organization's key performance targets are, your business case shouldn't negatively impact that. So an example, or you have to mitigate it. So an example was I had a radiologist talk to me about, we every so often we run these kind of Dragon's Den type things where people pitch business cases and we go through them. And in this case, somebody pitched a radiology screening thing for breast cancer, where rather than doing mammograms, they put a drip in and they injected some sort of dye or drug, and it increased the chance of finding of cancers, breast cancers. Okay. It sounds great. It had good specificity, good sensitivity. It was all good. But it reduced the number of people you could be seeing per session. So if you were, instead of seeing 10 people per session, you could only see 5 because each procedure took longer. Unless you mitigated against that, you're going to negatively affect the 2-week wait or the cancer targets. Okay. So you need to make sure that when you're aligning these things, you're clear how you're going to mitigate it. It's got to align to the organization's ambitions and plans. The next bit is probably the hardest, but one of the most important. It's your case for change. And this is where you need data. So whether you use Plix data, whether you use model hospital data, you need data to show why your business case needs to be proved. What is the problem? So highlight the problem, make your argument. Okay. You can use benchmarking data. It can be data related to CQC reports. They tend to be quite strong, the CQC reports. GERFT currently is getting it right first time. Reports are good, depending on how badly you're performing, can be very important. If you're borderline, it probably is not as strong as not strong evidence. Model hospitals are a good source for data as well. But you've got to make sure that the data going in to model hospital is accurate, because it can skew things slightly. NICE and Royal College recommendations, whilst again are good and nice things to have, there are so many nice recommendations, so many Royal College recommendations. And when I speak to clinicians, they go, well, the Royal College said this, or the Royal College said that, we need to have it. But if you think about how many Royal Colleges there are, how many recommendations they have, if we were to try and keep up with that, there'd be no money left. So they are nice things to have, and they will help bolster your rationale, your reasoning, but you cannot rely on them on their own. Okay. Unless they're key critical thing, patient safety things that you've shown that there are other issues that are, of course, that. So mortality reviews, root cause analysis, also again good to argue your case for change. To give you an example of how you can use data, so this is unfortunately a lot of my examples will be either be surgery or theatre based because of the nature of work I do. So this is something from the model hospital. So this is about how we use a particular anaesthetic gas. Okay, this is really bad for the environment, and we at our trust we're using much more than everybody else. So we used it to justify purchasing a different type of some pumps, which we can use as an alternative to the gas. It came from sustainability funding, so there was funding particularly for environmentally friendly things. So we used this graph to show that we were high users. We needed these bits of equipment, and we got X amount of pumps, and now we are desflame free. So our use is now 0 and has been for a couple of years now. So again, use the data. Graphs can really show good data, providing they mean things. And I'll show you examples of when they don't mean anything later. Another example, again, taken from the model hospital. Okay, this shows our where we are, which is the black little column, and this was a few years ago. The black column in terms of our length of stay for emergency appendicectomy operations of less than 2 days. And we weren't performing very well. And then when you looked at the data in a bit more detail, Okay, it wasn't because our surgeons were particularly difficult or we had a long length of stay post-operatively. We had difficulty in accessing emergency theatres, where our emergency theatre capacity wasn't sufficient because they were waiting 2 days for an operation. So you can use this data to justify expanding your emergency theatre provision, and that's what we did. Okay, so you can use the data to make your arguments. Again, this is just building up your case for change. The next bits are your background. Okay, so by that I mean, what are your current business needs and current situation? So you can look at your current situation. What is it you currently work on? How are things going to change? So what you don't want to do is look at this year in isolation, or your current situation in isolation. Look at how things are trending. If your workload has increased by 2% every year, factor that in when you're looking at your business cases. Okay, because what you don't want to do is come back in a year and go, well, we need more now. Okay, because that won't be looked upon well. If you can show that you're predicting 2% increases for the next 3 years, and you factor that into your business case and show that you've got forward thinking, that will show you've developed good assessments. Okay. So your existing arrangements, your current needs, and future plans, potential scope. So scope is what's going to be what realistically is going to be within your scope of this business case. For me, emergency theatre capacity, I would love to have 3 new theatres or a whole new theatre complex, but that's not within my remit. It's not going to be something that I can be able to achieve easily without a much bigger business case. So the business case for this the appendicectomy thing was all about expanding the staffing models, okay, so we could operate more theatres more often. So what is it that your potential scope? What's going to limit you? Okay, for most people, it's estates. So most people, when you're talking about service development, the thing that limits what you can do is your estates and facilities. Whether it's outpatient appointments, whether it's logistical office space, that kind of stuff limits what you can do. So what is the scope of your project? Then there are 3. It's got benefits and risks, but there are actually 3 things. What are the benefits? So what are the improvements? What are the good things? Okay. What are the risks, which are the potential things that could go wrong? And then there's this word that's used in this concept called disbenefits. Okay, and they are basically bad things that will happen, like the fewer people that you might see in that radiology example. Okay, that's a disbenefit unless you mitigate against it. Okay, so benefits, good things; risks, potential bad things; disbenefits, actual bad things. It's a bad word, but that's how they use it in the official context. Constraints and dependencies. Again, constraints are what's going to limit you. Okay, what's going to limit the scope of your business case? Okay, is it that actually we can't recruit, so there's not enough of these specialists around, so we're not going to be able to recruit this minute. So there's no point going down that particular avenue. So what's going to constrain you? Estates, again, big constraint. Dependencies are where you've got one service or another business case that are dependent on this business case going through. So it's not necessarily a program of business cases, but one is dependent on another. Okay, so you might have a business case for a new build operating theatre, say for orthopedics. Okay, and another business case is for radiology support for that theatre. Now, without that radiology support, the orthopedic operating theatre won't be very efficient. So that they're dependent on each other going through. Okay. So what's going to depend on your business case? Spending objectives are what are you going to spend the money on? So what is the resource that you're asking for? Is it for estates? Is it for procurement? Is it for kit? Is it for personnel? Okay. What kind of stuff are you talking about? That's your strategic case. So to give you an idea of how to do demand and capacity modelling, look at your activity. So this is a radiology one. So look at the numbers you're doing across a couple of years, forecast how much you're doing for that, and then you can work out what that actually means in terms of capacity. So this is, in order to factor that in, you would need X number of lists. This is X number of lists per year you would need. Okay. The bit in the grey depends on the payment system involved. So I've left it in grey because sometimes it does increase your income depending on what payment system is in vogue at the time, and sometimes it doesn't. If it does, put it in. If it doesn't, don't. So this is an example of how to do demand and capacity modeling. So we're going to move on to the economic case. And again, this is where it's very clear where a solution has been pre-picked. What you've got to do when the people writing you as people writing business cases will tend to be pretty knowledgeable about your areas that you're writing about. Okay, you'll know what's viable, what's not viable. Okay, the people reading your business cases don't. So the other thing that has been noticed when you're doing business cases is if you use too much technical terminology, whether it's clinical terminology, whether it's specific to your area terminology, people will get lost because they are not experts they're experts in their field, but they're not experts in your field. Okay, so when you're thinking of your long list, think about all the potential things that you could come up with, that if somebody external was looking at it, what would they say would be a potential solution? Well, why don't you do this? Why don't you do this? And it demonstrates you thought about it, and this is your rationale for not including them. Okay. Your assessment criteria. So what are your critical success factors? What are your essential criteria? And then what are your desirable? So if you think about your job descriptions, you have desirable, essential, and desirable. Same thing. You can weight it. You can weight saying, of your desirable, this is more important than that. So you can come up with an assessment criteria to rationale your options. Okay. And that's what you have to do. You have to come up with a long list, have some assessment criteria, and show why these particular options have been shortlisted. Okay. If there are some circumstances where it's clear there aren't that many options and you go straight to shortlisting, okay. But you do need at least three shortlisted options. Okay, and it includes a do nothing or minimum option. And as I said, this is where it shows where somebody's thought about it and somebody hasn't thought about it and just come up with a solution. Okay. Then you do your kind of economic and appraisal, and that's your qualitative benefits. Okay, so that's not this is not a financial benefit. This is what are the quality improvements for each of those options? What is the impact on those options? And then you do broad cost appraisal. So when I say broad, I mean very simple cost appraisal, just ballpark figures. So you can have an idea of what level of funding you're needing. Okay. Because in most cases, the process will depend on the level of funding. If you need, millions of pounds, you need to go to NHS England. If it's less than that, then it might be done at commissioning level. It might be done at within your own organisation. Okay. So options appraisals can be quite difficult to come up with, particularly if you're not sure of how to do one. So this is a suggested way. Okay. Again, this is taken from the Green Book. This is the Treasury's public sector guidance on how to do business cases. So this is a clear way of demonstrating how you've produced your options, and it's quite a nice way I found. So the scope is what? Now, the example I use for this, because everybody comes from different backgrounds, is a very simple one. Okay. So the problem is we're going to do a railway one, completely non-health one. Okay, a railway one. So the problem is there's a lack of capacity on the rail network between London and the rest of the country. So what are your options? The minimum option is to improve the rail network between London and Birmingham. The intermediate option is to improve the rail network between London, Birmingham, and the Northwest. The maximum option is to do London, Birmingham, the Northwest, and to the Northeast, Yorkshire, wherever it was. Okay, so there are your three options. Each of these different components are independent of each other, really. Okay, so it could be to have a maximum option would be a clinic, multidisciplinary clinic. A single option would, a minimum option would be a nurse-led clinic. An intermediate would be a consultant-led clinic with, consultant-led clinic. Okay, so what it is what's your scope? What is it you're trying to achieve? The solution is how you're going to achieve that. So the minimum option is to refurbish the existing tracks. The maximum option would be to build new tracks. The intermediate is a mixture of both. The who in the healthcare context is who's going to be delivering it. Okay, so in this context of the rail networks, there's local, national, and international contractors. Doesn't really apply to us, but it could be, do you want a nurse specialist? Do you want a consultant, a registrar? Do you want a multidisciplinary team approach? Okay, so depending on the type of thing you're doing, who's delivering it? Okay, implementation is when it's basically about how you're going to roll it out. Is it going to be a big bang, all at once rollout? Is it going to be a gradual, step-by-step rollout, or is it going to be piloted and then rolled out? So you've got different options there. And how is it going to be funded? Okay, is it going to be funded externally from commissioning? Is it going to be a mixture of different funding streams? Is it going to be, is it going to be funded internally? For the example of the rail network, it's basically public, private, or mixture of both, just so to give context. Okay. So you do your options appraisal. Things that are clearly not viable, you highlight in red, and you write this in the bit below it, but you kind of highlight in red and go, these are non-viable. The yellows are the viable, and your green are preferred. And that way you can demonstrate how you've got to your solution that you wanted, or how you picked what you wanted. It's a very nice way of demonstrating that. So that's your option appraisal. So finances, again, I'm going to touch on this very briefly, because I said you do need finance involvement. Okay, so where is the funding streams coming from? Is it from, is your funding coming from which source? Is it from commissioners? Is it from within, from cost savings within your own organisation? Is it from other sources? There are national pots of money around. Is it from an education fund? Is it from a sustainability fund? There are various pots. Okay. Are the commissioners interested in the service or in commissioning the service? Okay, so what level of interest the commissioners? Is it a service improvement project within your service, or is it a service that the commissioners are requiring? Okay, because then again you get more traction, because it might attract more money because they're willing to fund it. Okay, is the funding recurrent, as in ongoing, or is it a one-off? So you might find that for things like sequins, you might find the funding is non-recurrent, it might be one-off, or if it's for a specific purchase, it's a non-recurrent funding. Okay, but you might have ongoing expenses from doing whatever you're doing. Okay, so then does the income cover the costs? There are things like net present value and all these kind of concepts about which involve income and costs and how long it will take to make up the money if you're saying it's going to be cost saving. But that, again, you do need finance involvement to get those analyses right. Okay. And then your sensitivity analysis is, normally we do the financial assessment based on a particular amount of delivery of care. Okay, so X number of operations or X number of procedures. What is the number that's going to mean you're going to break even on the income versus expenditure? Okay. And what happens if you underdeliver or overdeliver? What's the kind of ballpark figures we're talking about in terms of cost and expenses? Okay. And in terms of budget availability, how much is already funded? So how much is internal funding and how much are you asking for? That's the broad parts of your financial case. So we've covered the strategic case. Is it needed? Why do we need to change? The risk benefits and equality can change. We've talked about the economic case. Is it value for money? What options have been considered and why have you chosen a particular option? We talked a bit about the financial case. How are you going to pay for this? Savings, loans, and over how long? Okay. So we'll talk a little bit about the commercial case. So the commercial case is again where you need specialist help. So the procurement process has lots of different legal ramifications. There are lots of procurement regulations that mean that if you're putting things out above a certain value, you've got to do certain processes. What I would say is you've got to factor in the whole life cost, okay, of whatever. If you're buying something, bit of kit, equipment, what is the cost over the lifespan of that equipment? Okay. And be wary of signing, particularly for small amounts, for small bits of kit, particularly be wary of signing contracts for multiple years. Okay, so especially if the clinicians ask for it. If the clinicians ask for it and they want a bit of kit, then unless it's if it's £1 million robot, that's one thing. They have to use that for 10 years. Most other bits of kit will go out of date quite quickly. So there's no point signing up to a 10-year program unless they have kind of upgrade within it, a kind of automatic upgrade process within it, because otherwise you'll be stuck with kit that nobody wants to use in 5 years because the kit improves. You've got to look at what the upfront cost is versus the ongoing cost, and it depends on your use. Okay, so you might have a bit of kit that has a big upfront cost, okay, but has a very low ongoing cost, so consumable cost, and that's great if you are if you're a high user. Okay, if you're doing if you're going to use the consumables loads and loads, then that might work out cheaper over the length of the contract. If it's a bit of an emergency kit or some kit that you don't want to use it's only there as a backup, you might be better off paying a smaller upfront cost and then having a higher consumable cost, because actually over the length of the lifespan of the bit of equipment, you might not use it as much, and that might work out cheaper. Okay, so look at the whole life cost. Contract issues, you've got to be wary of existing contracts. So if your organizations are already contracted to do for a beta kit, okay, then and you buy in another bit of kit, you've got to make sure either the contract allows that, okay, they're not competitive, because if you've signed up an exclusive deal with one company, you may not be able to get another bit of kit from another company if the original company already supplied that kit. And if you don't have that as an issue, make sure they're compatible. Okay, so we've had issues where we brought in, our trust has a contract with, Dell for computers, let's say, and a bit of kit that we brought in has a HP computer built into it as part of the kit. Okay, now it's taken us months to get it online because of the trying to compatibility issues between the drivers, in terms of IT. Okay, so that would have been avoided if we'd been aware of the contract issues in terms of compatibility. And then the final thing about personnel requirements is all about how you work it out in terms of costs. Okay, so for consultants, you take it's 42-week delivery is what we generally use as our number, okay, because that's what the consultant contract requires. So if you're putting in a business case for a consultant-led clinic for a year, okay, 52 weeks of the year, then you need more than one working time equivalent, okay, because one working time equivalent for consultant delivery is 42 weeks of the year. A lot of our contracts now are for 42 weeks of the year rather than for 52 weeks of the year, just because it just helps and it's easy to keep track. But if you do have a 52-week year requirement, you've got to either build in prospective cover, or you've got to make sure that your funding is for 1.2 or 1.3 working time equivalents, which is how much it would be. HR know that in more detail. And the same with junior doctor, resident doctors, the new name, and for agenda for change contracts. Again, you take the midpoint of whichever banding you are looking at, and it's based on a 37.5 hour a week contract. Okay, so if you want delivery of an extra nurse on a ward 24/7, that's multiple working time equivalents. Okay, and HR people services will be able to give you the idea of how much that would be. So you're going to need to factor that in. Okay, the final kind of component to the 5-case model is the management case. How is it going to be delivered? So again, we talked about rollout. So how are you going to implement it? Okay. What is the impact of service delivery? So in terms of that, there's multiple kind of components to that. If you're starting a new clinic, a specialist clinic, then if you can show that actually that will free up time in other areas. So say you're starting a specialist Parkinson's clinic for people with Parkinson's disease. Okay. They're being seen in the general neurology clinic. If you are freeing up slots in the general neurology clinic, then there's going to be benefits to the service delivery of the general neurology as well as specifically for Parkinson's. Okay, so there's mutual benefits for both sides. If you are using the hours and the time for those doing the general neurology clinic into the Parkinson's disease, then there's going to be an impact on the service delivery of that general neurology clinic. So you need to factor that in. What is the impact on the other services around you because of whatever you're doing? But that's both short term during the implementation phase and long term as part of the implementation of whatever you're trying to do. Okay, so what's the impact of service delivery? Do you need to factor in during the rollout a contingency? Okay, what happens if in the case of Midlands Metropolitan, your construction company goes bust? You know, you make a plan for a specific date, and then something happens, or there's an IT delay, okay, or there's something happens that delays your start date. What is your contingency? Okay, you need to have a contingency on your service delivery plans. Okay, and what is the effect on that? Do you need to have a backup? If it's a major change? So when we moved our transplant services, for example, from one site to another, we had to we had to consider whether we needed to temporarily divert our emergency transplant service to another hospital for a day or two, where we had equipment at one site, patient at one site, on other sites. So, is there going to be an impact where that happens? Okay. So what is the impact on service delivery? Okay. So they are your 5 main cases. The next few minutes is some talks and tips. So you need to engage the people that are going to be presenting the business case, the people that are going to be part of the decision-making panel, okay, and all other stakeholders that are involved and may be affected by the business case. Okay, generally, the more people you can get on board to support your business case, the more likely it's going to be approved. So if you're doing a business case and you get the support of the other specialities or other areas that may be affected by it, okay, then they're more likely to get it approved. Get people to ask their feedback, address their concerns. They may have thought about things from a different perspective and may have identified issues that you may have not thought of. So incorporate their suggestions, address their concerns. Okay. Again, with most of these things, you're more likely to get a business case through if it's supported by multiple groups. Okay. And if you don't do that, you might find that business cases get blocked very early on by other areas because they say, well, what about the effect on us? What about the effect on us? If you factor them in and explain your rationale for this, that, and the other, then they'll be more supportive. So make people part of the process. Timing is important. Okay. This isn't a kind of all in thing, but small business cases tend to get more traction towards the end of the financial year because NHS money is in pots, and if you can have a business case that is meant by a specific pot, especially if it's non-recurrent money, so if it's one-off payments or one-off purchases, okay, they tend to be useful at the end of the financial year. Things that have recurrent costs, okay, particularly things like new services, if you factor the planning from the start of the financial year and it gets factored into the commissioning arrangements and everything like that, then you're more likely to get it approved. Okay. And you've got to think about timelines for recruitment. So again, have realistic timelines in your management case and in your personnel requirements. What are your timelines? There's no point saying we're going to start this in 3 months if you need to do recruitment. Okay, because recruitment can take up to 6 months, a year, depending on how what people's notice period is. You've got people who may be need to for consultant jobs. You may people who people can apply to consultant jobs 6 months before they're eligible to start. Okay, so you've got to think about recruitment timelines. Royal College approval for jobs can take a while for consultant jobs. So things can take a while to progress and get people into post. You maybe say, I want locum funding to start with. Okay, but you need to make sure you factor all that in. So appropriate timelines, try and plan for funding for the start of the financial year for new services. There are lots of other sources of funding. So for IT funding, there was various pots of money in the Digital Transformation Fund. You can get money from educational sources if your project is education orientated. Now, at the moment, there's still a differential between system funding, so within your ICBs, and specialised commissioning, which is currently done by NHS England to the most part. Over the next couple of years, that difference will start to shrink as more and more services, specialised services, get delegated down to the ICBs. But currently, just work out who's going to benefit most from your project. Is it the ICBs, or is it stuff that's going to be that's commissionable from specialised funding? And then combine with a large business case. Okay, if you're having a multi-million-pound build in a business case, a small bits of money for equipment is not going to be, it's neither here nor there, and you can piggyback almost your business case onto a large business case. So that's some tips. Things that you need to try and avoid are things that may actually cause more confusion. So this is something that was in a business case I was reviewing, and it makes no sense. You end up having to, so diagrams should be there to illustrate things instead of text. But actually with this diagram, you need to read the text to understand what this means. Because I don't know if perioperative care impact is a good thing or a bad thing. I don't know what kind of timeline we're talking about on the bottom row. Okay. Graphs that are poor, because they're eye-catching, graphs that don't make sense massively disadvantage your business case. Because you just don't know, it causes more confusion. As with, concepts like this makes no sense. This was for an application for electronic pre-op assessment, but there's no context to it. It didn't flow in the text. It doesn't really make any sense in terms of, it's a nice graph, but it doesn't actually has no context. Okay. The ideal business case should have the problem being addressed, or the intended benefit is clear and evident. All potential options should have been considered, and you have a good rationale. You've got a good reasoning for your preferred option. Okay. You've talked to all the stakeholders, and they've been consulted as part of the process. You've demonstrated value, as shown in the value equation. You've got a feasible implementation plan. You've got some contingency factored in, and you've got realistic timelines. Finally, the opening lines of a business case can be really important, and they can set the tone of your business case. Okay. This was something, again, this is an opening line to business case. I'm sure this makes complete sense to the person that wrote it, but as somebody who's, even though I'm involved in pre-op assessment, I'm not involved in this is a very wordy and quite in-depth opening statement. What you prefer is something that's a bit more punchy. It's not quite a mission statement type thing, but you want to make it very clear what the whole purpose of this business case is to do. Okay, so you can see the difference between the two. These are probably out of date now, these links, but we will try and get you. So NHS oversight metrics, NHS system oversight frameworks give you a good idea of the KPIs, the important KPIs you need to look at. You may probably have that already. This is still relevant. These are templates and some stuff on details about business cases and the project business cases, which are available on the government websites. And that's your kind of guidebook for all business cases. Okay. Again, they are not specific to the NHS. They're across the whole public sector. They have various checkpoints, and they have various processes. There are 3 steps to a business case. You've got your strategic outline case. Okay, for the big business cases, you have 3 steps: strategic outline case, your SOC, your outline business case, and then your full business case. Okay, and this concept has multiple checkpoints within that. Okay, for most people, for most people within the NHS, you miss out one of those steps, unless you're doing a new build multi-million-pound business case, in which case there is 3 steps. Most business cases just do 1 or 2 steps. Okay, you put it in, and they may come back and come up with a full business case once you've done the procurement. Okay, but the key components are still the same. Okay, the key contents is still the same to a business case. That is my very quick overview of how business cases are. I've got a couple of questions, I think, but I'm happy to answer any questions now. We've got half an hour or so in the diary for it, so slides will be available. I'm trying to put together a repository of business cases that are going to be anonymized, that people can use as sorry, I don't know how much of that you got. I'm trying to put together a repository of business cases that are anonymized, that you can use as templates and as guides to help you put business case together. It's going to be on the One NHS Finance website, and will be put together hopefully in the next couple of months. What you'll probably find is you only tend to find good business cases online. You don't tend to find the ones that aren't successful, and most of the ones that do get published tend to be the big ones. that where there's a lot of detail in there. You don't tend to find the smaller ones, which is what we're trying to get together. Okay.